In this video, I will discuss inflammatory myopathies. Mostly, I will discuss polymyositis and dermatomyositis. Myositis is the inflammation of the skeletal muscle. There are two main idiopathic inflammatory myopathies. First one is polymyositis, in which there is only muscle inflammation present but skin involvement is not present. In dermatomyositis, there is muscle inflammation and also there are characteristic skin manifestations like skin rashes. Other myopathies are also seen like inclusion body myositis, statin-induced myositis, etc. But I will discuss dermatomyositis and polymyositis in detail here. Etiology and pathogenesis. So, dermatomyositis and polymyositis both are autoimmune diseases. These are T-cell mediated, leading to muscle fiber injury. In case of dermatomyositis, mainly there is humoral attack mechanism on the endothelial DM, leading to muscle ischemia. It can be idiopathic or it can be associated. That is, dermatomyositis has association with malignancy. So it can be idiopathic or it can be associated with malignancy. Myositis can be drug induced, as I have told you, for example, due to statins, hydroxyurea, cyclosporin, steroids, etc. Clinical features. In case of myositis, there is muscle inflammation leading to symmetric proximal muscle weakness. You should remember that there is involvement of bilateral muscles and proximal muscles like shoulder muscles and pelvic girdle muscles. So shoulder and hip girdle muscles are involved. In this way, patient is unable to raise from chair, hip girdle muscles, and unable to comb hair, hip girdle muscles, shoulder muscles, and also unable to climb stairs, hip girdle muscles. There is no facial or ocular muscle involvement. No facial or ocular muscle involvement. It is important because in this way we can differentiate them from myasthenia gravis. Muscle tenderness and pain may be mild or absent. If there is increased muscle tenderness and more pain, then it leads more towards polymyalgia rheumatica. And if it has less muscle tenderness and less pain, it means there is no polymyalgia rheumatica but myositis. Systemic features. Systemic features are present in every rheumatoid condition like fatigue, fever, weight loss. These are characteristic for other autoimmune conditions also. There may be dysphagia due to skeletal pharyngeal muscle involvement. Dysphagia is due to skeletal muscles involvement of the pharynx. Respiratory muscle weakness can be present in severe cases leading to dyspnea, carbon dioxide retention, or hypoxia. In some cases, arthralgias and Raynaud's phenomenon are also seen in polymyositis and dermatomyositis. In case of dermatomyositis only, you will see skin features, while in case of polymyositis, all other features may be present, but skin features are not present in polymyositis, while skin features are present in dermatomyositis. In case of dermatomyositis, heliotrope rash is present, that is purple discoloration of area above eyelids. Here you can see purple discoloration of the area above the eyelids. This rash is present like this. This is heliotrope rash. Then Gottron's papules are also seen in dermatomyositis. These are erythematous scaly patches over your knuckles. Here you can see erythematous scaly patches over your knuckles. These are present over the DIP, PIP and MCP joints. Then you have shawl sign. Shawl sign is present due to rash over shoulders, on your neck, and also on your upper back. Here you can see like patient is wearing a shawl sign, rash on the neck, back and upper shoulders, shawl sign. Then V sign is also present, that is rash on anterior neck, like patient is wearing V-neck shirt. Mechanics hands. Mechanics hands are present in the antisynthetase syndrome. Antisynthetase syndrome. It can be seen in polymyositis and dermatomyositis both. So patient has rough, cracked skin on fingers due to hyperkeratosis, and it is present in patients who have anti-Jo1 antibodies mostly present. Mechanics hands, antisynthetase syndrome, anti-Jo1 antibodies. There may be periungual telangiectasias. Investigations. You should go for creatine kinase. If the patient comes to you and he has difficulty in combing hair and lifting him or herself from chair, then you can go for creatine kinase and check if it is elevated up to 10 times normal. And aldolase should also be done. It is also elevated. AST and ALT should also be elevated, but they come from muscle. LDH is also raised, and autoantibodies like ANA is also raised. Other autoantibodies like anti-Jo1, anti-MI2, anti-SRP, these are characteristically present. So mainly you go for creatine kinase, it is elevated. Aldolase, it is elevated. ALT, it is elevated, comes from muscle. LDH may be elevated and ANA may be present. Other antibodies that are specific for dermatomyositis and polymyositis are anti-Jo1 antibodies, anti-MI2 antibodies, and anti-SRP autoantibodies. If these are present, you can also go for electromyography. EMG shows myopathic changes. So electromyography shows you myopathic changes, and then you go for MRI of the muscles first. MRI of the muscles show muscle edema and inflammation, and once you know the site of inflammation, then you take muscle biopsy. Muscle biopsy shows inflammatory infiltrates. Inflammatory infiltrates are perivascular in case of dermatomyositis. In case of dermatomyositis, these inflammatory infiltrates are perivascular, while in case of polymyositis, these inflammatory infiltrates are fascicular, that is, muscle is involved in inflammation itself. You should also go for malignancy screening, because I have told you dermatomyositis has very strong association with malignancies, especially ovarian malignancy. So you should go for malignancy screening also, especially ovarian malignancy. Differential diagnosis. Muscular dystrophies like facioscapulohumeral dystrophy, hypothyroid myopathy, because it also involves your proximal muscles. Drug induced myopathy, as I have told you, statins also involve proximal muscles. Inclusion body myositis, I have told you in the beginning that it is also a type of myopathy, inclusion body myositis, but it is mostly present in males. It has less inflammation. It responds less to treatment. And it involves your distal muscles, and in this way you can differentiate inclusion body myositis from polymyositis and dermatomyositis. How will you manage this condition? There are general measures. Patient should do rest during the acute phase of the illness. Patient may require physiotherapy in later disease. Screen and treat any underlying malignancy if it is associated with dermatomyositis. Now we come to main treatment. Main treatment is pharmacologic treatment, and it depends mostly on the corticosteroids. Prednisone is given as 1 mg per kg per day, and it is then tapered according to the response. You should monitor creatine kinase levels and also patient strength, and accordingly you should taper this prednisone according to the creatine kinase levels and according to the muscle strength. According to the muscle strength and according to the creatine kinase levels. Then immunosuppressive agents. Immunosuppressive agents are actually steroid sparing agents. Mostly we use either methotrexate or azathioprine, but we can also use mycophenolate, mofetil, and cyclophosphamide. This cyclophosphamide causes premature ovarian failure in young females. Therefore, you should not give these to young female. Biologic therapy for resistant cases is also given. For example, rituximab, And IV immunoglobulins are given when there is severe dermatomyositis that does not respond to other conditions, or if there is inclusion body myositis, then we go for IV immunoglobulin. These are very much expensive. Topical corticosteroids are given for skin rash, and HCQ, hydroxychloroquine, is given for cutaneous involvement in dermatomyositis. This HCQ is very good for cutaneous involvement in dermatomyositis. So this is all about dermatomyositis and polymyositis.